Thank you so much for joining us for First Fridays. Today, we are talking all about best practice in pediatric care, and we have a wonderful facilitator and expert in pediatric care with us, Mindy, who will share a little bit more about, and then you all will get to know a bit more throughout today's session. If you need anything today, please feel free to message us in the chat. There's a few of us monitoring the chat on NHP side, so we'll try to get to your questions quickly. Also, feel free to unmute yourself at any point during today's presentation if you have a question or a thought, or you want to talk through a scenario that you've experienced. We are totally open for you doing so throughout, or we also have dedicated Q&A time towards the end that you can save any of your questions or thoughts for. But here's our agenda for today. Right now we're starting with our welcome and introductions, and then we're going to pass it over to Mindy, and she is going to have a great presentation for us, and then we'll have some discussion, time for questions, and then we'll wrap up and do a survey, talk about our newly revamped First Fridays that are going to launch in February, and share some other ways that you all can get engaged with NHP. Does anyone have any questions about our agenda or need anything at this point? Great, we'll keep going. I already covered housekeeping a little bit, but just a reminder, we are also recording this session, not to record you all, but to record the presentation and any learning that is received today. And those recordings will be, the recording will be posted to our website next week. It takes a little time for us to edit them, but then that recording will be posted to our provider training page for folks to access. And then if you ever have peers or colleagues that weren't able to attend today, but you think this would be helpful for them, feel free to share that out with them as well. I just dropped that link in the chat. We will also send out meeting minutes and any notes or questions that we need to do some additional research or follow up on after today's session. So a few of you hopped on early, and I asked you to drop your name and practice or organization in the chat. For folks that just joined, if you could also drop your name, your practice or organization, or the counties you work in, and then something that you're most excited for this month or in the month of December. Does anyone want to share something you're excited for in the month of December?
I can.
Ski season.
Go for it, Kaylee, and then we'll go to Nina.
I just got a dog, so I'm excited to start training her.
That's so exciting, Kaylee.
Congratulations. I'm with Kim.
Nina, did you want to share?
Oh, I just was going to say ski season.
Yay! Yeah, finally here. Great. Thanks everyone for sharing. And we have a few people in the chat also sharing. So feel free to keep sharing. Oh, that's a great one, Sarah. Eggnog latte season. So good. I just tried Trader Joe's oat eggnog, and it's so good. Really, really good. Highly recommend. Okay, we're gonna keep going. So today we're welcoming Mindy Craig. Mindy brings over 25 years of experience in healthcare and a deep commitment to advancing high quality, team-based, innovative pediatric care. Mindy completed her PA studies at the University of Colorado's Child Health Associate and PA program. She has hands-on experience in nearly every practice role, really giving her a unique ability to understand and address the challenges practices face in an evolving healthcare landscape. So today we're really excited to have Mindy here with us. She is a resource for you all to access not only today, but in the future if you have questions or need additional support. Or once again, if you have a colleague or somebody else in your practice that may need to leverage some of her support, she is a resource for you all. So I'm going to pass it over to Mindy, and she's also going to share her screen. But Mindy, feel free to introduce yourself, tell folks a little bit more about yourself, and we'll let you get started.
Perfect. So, let me just move right on. So I thought I would start with just kind of a little level set. What we're going to talk about today is really some of the differences in pediatric care and why kids kind of need a different approach to healthcare than adults. This work really started with the CU Practice Innovation Program. If you guys are all familiar, or CHES, sometimes people refer to them as either the CU PIP. And some work that they did on request from HICPUF to really look at, I think a lot of the pediatric partners across the state have been pretty vocal for a long time about that the value-based payment programs that we have don't really reflect kids, and kids need to be treated a little bit differently. And so we were contracted to try to really lay that out in kind of more black and white terms, which is of course not possible, but try to come up with, what is this? Why are kids really different? So this first slide is just kind of a level set, and it's a really nice summary of why kids need to be treated a little different in value-based payment programs. This report came out from the National Academies of Science and Engineering and Medicine about a year ago, and it really did a nice job of defining, kind of breaking down why kids are different into these 5 different categories. So the first is really developmental change, and this kind of goes without saying, but kids are constantly growing and changing, and the care has to adapt. And, the care that you give a 2-year-old is very different than the care a teenager gets. And a lot of that goes to the third one there on dependence. And depending on the developmental age and stage of the child, the family is really part of the care and has to be considered in all care decisions, because nothing really happens without the family. Kids are, very deeply dependent on the health and well-being of their caregivers. And so the approach has to be family-centered or dyadic, or in some way bringing in the family. The disease epidemiology is also probably a big point of contention with a lot of pediatric providers, and just that kids tend to be pretty healthy. So the focus of pediatrics tends to be on prevention and health promotion, but a lot of the focus of value-based payments is really on chronic disease. And so it doesn't necessarily really account for where most of the focus is happening in pediatrics. We do know that kids are disproportionately affected by poverty, and the impacts of poverty are felt more in childhood, especially early childhood. And I think this is something that you all are very aware of. We talk a lot about ACEs and the impact of those adverse childhood events, and how it really can change the architecture of the brain in the development of that child. And so thinking through those things are another reason why hitting that prevention health promotion focus are so important. And then of course the dollars, and this is a big sticking point, where children make up 23% of the population, but really only account for about 10% of the healthcare budget. And people will argue, well, that's because they don't really get sick. But if you could put that money into prevention and health promotion, hopefully there would be quite a big return on investment. So the project that I'm going to talk to you about today was, as I said, it was contracted by HICPUF. The CU PIP program was contracted by HICPUF to really look at what would be, after hearing for years the pediatric providers, both family medicine and pediatric specific, saying that the value-based payment models really don't reflect kids. HICPUF said, well, what does reflect kids? How can we make this work a little bit better for kids? And interestingly, there really has not been a value-based payment, a pediatric specific value-based payment program that has been developed that has had enough success to really say, well, that's what we should do. So HICPUF wanted to really kind of get to get a little bit more information and wanted a research-driven report that looked at what really defines high-quality pediatric care. So what should be those competencies that we're looking for in value-based payment programs for kids? The report, I think, is really important to mention that the report identifies an ideal state, but it is very much recognized that current reimbursement does not support the achievement of the ideal state. So this is not saying that this is where everybody should be right now. This is just if we could get pediatric care to where it should be, it would be at this ideal state. And then, value-based payment programs would support that. The report was aligned, it was organized to be aligned with current frameworks that all practices and practice facilitators are very familiar with, really following the DOI's competencies and the framework that's already established that was, started years ago. I think the start was during SIM and looking at those 10 building blocks of high performing practices from Bodenheimer they were written for family medicine, and so didn't really capture pediatrics very well. So we aimed to kind of go through and organize the competencies into that same framework so that it would be, less confusing to practices and it'd be something that everybody already recognized. Once we had kind of come up with what we thought was the ideal state, then the next task was to go around the state and really identify where the gaps are, where people are, and what keeps people from meeting the ideal state, and then feeding all of that information back to HICPUF so that they understood what it would take to really improve pediatric care. In that gap analysis, we learned a lot, and that's kind of what I'm going to focus on today. I wanted to just kind of briefly review the building blocks in case anybody wasn't familiar with them. But we have these 10 main areas, and in some of these, the needs of pediatric patients really is the same as adults. So engaged leadership and value-based contracting are going to look almost identical. So in some cases, just some of the language is tweaked a bit. But in other areas, there's significant difference. So just so that you guys all know what I'm talking about, these are the building blocks that were used. And in that gap analysis, what we found were really, some trends that there's some things we can do now without additional payment and without waiting for all of that to come through that could really move the needle a little bit for kids. So the first is kind of recognizing what the pediatric care team can look like. The second is looking at how we engage families and patients in care and decision-making. Probably the most pressing that came up in every single practice we talked to, which is probably not surprising to anybody on this, is the need to address vaccine hesitancy. And then the last one, and definitely not least important, is really to ensure that the current recommendations for screening from both the Preventive Service Task Force and the American Academy of Pediatrics, making sure that those screenings are getting done, because with the focus of PEDS being on prevention and health promotion, of course, you want to identify things early so that early intervention can have an impact. And this was one thing that we were a little surprised with, that there's certain screenings that are not getting done in different parts of the state. So we'll talk about all of that today. So starting off with the care team, I think the AAP says it nicely that the pediatric care team is pretty comprehensive team, and it can include a lot of external providers as well as internal members. And the goal of this isn't necessarily that every practice is going to have all of these different disciplines, of course, as part of their internal team. The idea is that that there's a recognition that there are a lot of other players out there, and for the best care of kids, we should all be working together and coming up with some well-defined workflows to communicate and coordinate. So of course the internal core team members are going to be the family themselves, the providers, nurses, MAs, and then the enhanced team can look a lot different depending on the location. Some practices have really great workflows to include all of this, and some don't, and that's definitely expected. So I don't mean to say that everybody is supposed to have all of this, but if there's a recognition and there's a way to connect families to all of these different team members that can impact a child's growth and development, that would be great. So lactation support, behavioral health providers across the developmental trajectory, not just those teens. Early childhood specialists can be great for prevention, health promotion, occupational therapy, PT. School-based health providers, a lot of teens rely pretty heavily on school-based clinics, but there isn't always communication between the primary care and the school-based clinics. So trying to tighten that up so that the primary care provider really knows what's happening and is in the loop. Of course, early intervention and child find professionals and teachers who probably spend the most time with kids. So recognizing that most practices don't have the resources to develop this type of comprehensive team, one of the things that we wanted to look at across the country when we were doing interviews is, how do practices that are really high performing, how do they integrate these different things, and how do you strengthen your team? There's a lot of recommendations out there, including, it wasn't on the last slide, but even, having dental hygienists in primary care, which I think Salud, I think I saw was on, and I think they have this, but a small, 2-doc family medicine practice isn't going to have that. So how do you really integrate and make sure that you have the most comprehensive care team for those kids? And, the first thing that I think is important to recognize is just really strong care coordination and navigation. I think that sometimes this gets overlooked in some, in some things that are written about pediatrics, but it's really pretty essential to making sure that kids are really accessing all of those things that they need. Whoever is doing the care coordination really has to have a strong understanding of Colorado's developmental referral supports, which can be really confusing and complicated. And so, really understanding what that looks like, what the free resources are for families out there. One of the practices that we talked to, I won't identify the area, it was, a more isolated area, but it was, they had children that they thought looked like they might have autism. They weren't screening, so they didn't know where they fell as far as their risk, but they also did not have any knowledge of the developmental referral system. And so their first line of referral was to send them to Children's Developmental Unit, which is, a very extensive wait. And we know that early intervention is so important in kids with autism and other developmental concerns. So really having somebody in the office that fully understands how to navigate that system and how to connect those families to those supports that are available, and not wait for the specialty support that can take so long to get. With that, understanding what FERPA laws are is important, because it's hard to navigate the difference between, confidentiality in the education department and education world, and confidentiality in the medical world. Families are for sure in need of help with transitions, and I think this is only going to continue to be a really important part of the strong care coordination. Not just transition in early childhood. Services look very different for a 2-year-old than they do for a 4-year-old. So how do you make that transition? Transitioning to school age, and then of course transitioning to adult services is a huge need as well. So really working strongly with external partners on that. The other thing that we saw that could be something that could be fairly easy to implement is including an early childhood focus in behavioral health programs. In regardless of whether it's a pediatric specific practice or family medicine, adults and adolescents and their mental health needs can very easily completely consume a behavioral health provider. And early childhood is not really something that's thought about for behavioral health providers in a lot of cases. There is a program called Healthy Steps in Colorado that helps improve the access to early childhood behavioral health. But really kind of thinking through, you don't necessarily need to be doing a special program. You don't need to hire an early childhood specialist. But if you have your behavioral health provider that maybe singles out one visit, like a 2-month visit, and concentrates on doing screenings for the mom for depression, the child for development, and using that to kind of talk about what the behavioral health provider can offer and connect the family at that early stage can be really helpful. Oral hygiene, we talked about a little bit. There's a great program in Colorado called Cavity Free at 3. We do know that 3 applications of fluoride varnish before the age of 3 will decrease a child's lifetime risk of cavities significantly. And so getting that early fluoride varnish can be really important. And what we found is that there's some parts of the states where there are so many pediatric dentists that this is happening. It doesn't have to happen in primary care at all. Kids are getting their varnish and they're getting seen early, but there's other parts where this isn't the case. And some of the dentists are kind of more old school and don't want to see the kids until they're age 3, which means that you really lose out on that opportunity for that early fluoride varnish. So Cavity Free at 3 trains practices to know how to screen, talk to parents, and do that fluoride varnish application. And of course, practices are reimbursed for that. So it's by Medicaid. So it's a really great opportunity to add that extra support. And then lactation support, I think this is something that's been really kind of transforming in a lot of practices that have been able to implement it. Not everybody can, so partnering with a hospital, doing what you can to provide that lactation support. But if there were medical providers or behavioral health providers that were interested, doing the training and then providing that as a service to families can be really helpful. The new hobby codes, if used by the behavioral health provider, could support billing for this as well. So moving on to the patient and family engagement piece, this is something that I think pediatrics, I think pediatrics is a very relationship-based practice, right? You kind of have that whole family, so there's more of the relationship and recognition of that relationship than well, I wouldn't say more of it, but I think that there's kind of an assumption that patient and family engagement happens. But we do know, and I think adult medicine has been doing this for a long time, that by implementing, a specific tool or strategy to improve patient and family engagement, you can actually really make a big difference and make sure that your families are all on the same page as you are. So motivational interviewing, this has been used across all practices, I think, in the state, but really helping patients and families find their own motivation for behavior changes. I think motivational interviewing is a great tool to use. Agenda setting is something that has been done, I think, in family medicine, probably more than in pediatrics. I remember reading a study, it's been a long time, it's been about a decade now, that said that if a provider touched on all of the anticipatory guidance topics that are recommended in a well child visit under the age of 10, so any random well child visit under the age of 10, if you talked about everything that you're supposed to talk about, the visit would take 90 minutes. And we all know that's not the reality. So we also know that families really don't hear the things that they're not interested in or that aren't really important to them at that moment. They might not, there's something that they might not necessarily be interested in just because they don't know about it. And so it certainly is important to bring things up. But if they have something on their mind and that's not addressed, that's what they remember. So agenda setting can really get to that point right away. And there is some research that shows that having the provider themselves ask the question rather than having the MA or nurse who's checking in the family ask, what are you here for today? Is there anything you really wanted to talk about? Having the provider ask it tends to be a little bit better way to get to what that is. And it's a great way to really get families on the same page. And then the last thing is the shared decision-making tools. And this, again, has been used more in family medicine than in pediatrics. There are some really good tools out there. They just haven't been implemented as much. I personally think it's probably because family medicine has just had to get used to value-based payments a lot earlier with, if you took Medicare, you were jumping in a bit before the pediatric specific practices jumped in. And I think that, that's probably kind of some of what drove all of the different practice transformation tools. But sure, there are some great ones for kids. And on the next slide, these all have links. So you can just click on these and these will go to these specific links for these decision support tools. So the idea behind, if you're not familiar with decision support tools, is that it's a specific tool that gets at first, what are the family's priorities, values, and just wishes and desires, regarding whatever treatments you're offering. And then when there's more than one treatment option, the tools will go through and look at what are the pros and cons for each different option so that families can make really informed decisions and decide what the best thing is for them. The decision support tool for otitis media, I have a lot of practices that really like this. It talks, really about whether antibiotics are needed and how do you address that and the different ways that families can kind of get involved in that, really making them more active participants rather than just telling them what you're recommending. Same for ADHD, really looking at all of the different medications and finding out what the values are for the family, what's important. There's some great vaccine tools out there. Unfortunately, a lot of these, this HPV one, I still have the link for. I think it's either Canada or Australia that put these out. The ones that we had with the CDC have all been taken off the website, so those aren't available anymore, unfortunately. If you can find an old one, there's some really good ones out there that can really help get families involved in making informed decisions for their kids. The asthma one is great. This video is a really fun motivational interviewing demonstration that can be, it's on childhood obesity, but it can really be related to anything. So, and that's a really good resource. And then for practices that are seeing autistic patients for behavioral health medication treatment, this is a really good one for that as well. So one of the things that we found across the state is that it didn't matter what the practice was, family medicine, pediatric, FQHC, small independent, rural, urban, suburban, every single practice we talk to is experiencing some frustration with vaccine hesitancy. And it seems like, it's definitely taking a toll on providers. So as more and more families are coming in unsure in general, providers are expressing fatigue with having the conversations that can affect your job satisfaction and lead to burnout. Some practices have addressed this by deciding to require families that come to their clinic be vaccinated. That really eliminates that second bullet there, where providers are not feeling that strain of having the conversations and getting burned out. But then it leads to problems down the road for other practices that maybe are not, doing that same thing. So then they become a little overburdened with unvaccinated families, which then can impact their quality measures. So it really doesn't matter, I think, where you're at with this. The vaccine hesitancy is impacting, it's having a big impact on practices, and it's something that needs to be addressed. And I know Becca and her team are looking at ways to kind of get some good educational material or good speakers in for talking about this topic, and research that's been done specifically in Colorado. So I think that that'll be really good and something to look forward to. Just kind of to level set for the project that we did and the report that we submitted, we strongly recommended that that performance on vaccine rates not be included in value-based payments. We think it's important to be able to measure and know where you're at, but we don't feel that that should be part of, any value-based payment. Whether or not that has weight, we'll see. So the pediatric screening schedule, again, this is something that I was kind of surprised to find that a lot of these screenings aren't happening across the state. I've worked in the pediatric screening area for many years, over a decade, in helping practices, starting with just the developmental screening. And so I think kind of, to me, I kind of thought that we were there, but it's clear to me that there's still practices that need help with this. And that's okay. It's a lot of screening, and it's a lot to throw out there, especially if you don't understand the referral resources in your area. I think that can be really frustrating to try to screen and then not know what to do with somebody. So the ones that we're going to talk about today are really just the basics. So general developmental screening is recommended at 9, 18, and 30 months. The most commonly used tools are the ASQ and the SWIC. I'm going to talk about the SWIC specifically a little bit. Then autism-specific screening is recommended at 18 and 24 months. The general development isn't as sensitive at picking up autism risk, and so that's a really important one. Across the state, only 60% of kids are getting screened once. Much less than that are actually getting screened twice. So we know we're missing a lot of kids. And the reason this is important, and the reason these two ages were selected, is because there's much greater efficacy of treatments when started early. So we want to find kids with autism risk as early as possible, because treatments will be more beneficial. And also, it's easier for kids in the state to be connected with services the earlier they're connected. So if they can be connected long before their third birthday, really before age 2.5, then the services are going to be just a little bit easier and a little bit more consistent. So doing that autism specific screening is important. And the MCHAT is the most commonly used screen. But again, the SWIC has a little place here, and we'll talk about that in a second. Adolescent depression, I think that seems to be going pretty well across the state. There's still a few practices that weren't doing that. The new thing, of course, is to add the suicide risk assessment. And if you have practices, or if you're a practice that isn't doing that and would like some support with it, there's a great program out of Children's that is offering a lot of assistance for practices to start doing suicide risk assessments and feel confident with it. I've worked with a lot of practices who have participated in this program, and they've all absolutely loved it and felt like they benefited and really improved their care. So I'll include that in the handout that Becca will send out after, in case anybody's interested. And then maternal depression. And again, this was another one I was a little surprised with. Some pediatric specific practices are still feeling like this isn't their lane and they're not comfortable with it, even though both the American Academy of Pediatrics and the U.S. Preventive Service Task Force recommend it to be done with the well child visits. So it's, I think that there's not a lot of follow-up for moms after birth. And so if you're relying on the OBGYN, you're really giving it one shot at 6 weeks. And if everything is going well physically, we're not going to catch them. So the well child visit is the best place for that to happen. There's a couple of things here. The Edinburgh is the gold standard, but the PHQ works fine too. If there are any family medicine practices that are treating moms that have depression and would like any additional support for that, the Postpartum Support International is an amazing organization, and they actually offer free peer-to-peer consultation for U.S. medical providers with a psychiatrist that specializes in postpartum depression. So if you are, in a situation where you're wanting to treat, or you have providers that are interested in treating, but it's, kind of scary because if maybe the mom is nursing and you're a little uncertain of what medications would be the best, the Postpartum Support International is a really great support for that. And again, that's free. You can just click on that and book an appointment right online. So going back to the SWIC, we talked about how much anticipatory guidance is taken over in the amount of time it would take to talk about everything. Well, screening, I think, is one of those things too, where when we started with just developmental screening 15 years ago, there weren't a whole lot of other screenings in place, but now we have general developmental screening. And I think I mentioned that the ASQ is the most common, but the ASQ is pretty lengthy screening tool. So then when autism screening is also recommended at similar ages, and then you also have maternal depression, and then people are looking at social determinants of health and all of the different screenings that come in. Keeping all of those things straight and keeping track of them can be kind of hard. So the SWIC is a tool. It stands for the Survey of Wellbeing in Young Children. And when the slides go out, all of these are linked to where you can find information on these and get them. The SWIC is a screening tool that's meant to go along with all of the well child visits, 0 to 5 years of age. And it has all of those recommended screenings built into it. So it has general development. At ages 18 and 24, it includes the critical parts of the MCHAT to screen for autism. It includes, at the early childhood visits, it includes the full Edinburgh for postpartum depression. At ages 1, 2, 3, and 4, then it switches to just PHQ-2 to just screen for maternal depression. And then it also asks some social determinants of health questions. So it's a real comprehensive screening, and it is much shorter than doing everything individually. So all in all, it takes about the same amount of time as the full ASQ. But then is a little bit more comprehensive. And so a lot of practices are looking at this. Colorado Medicaid recently, well, not recently, it's been a couple of years, but they changed and now include the SWIC as a tool that is approved for billing for all of these things, as long as you do the entire tool. And then you would bill for each of those. So if you're at an 18-month visit, you would get the general development and autism specific. If it's a 4-month visit, it would be general development and maternal depression. So the thing that I like best about this tool is that it is freely available. It's in the public domain. So practices can get it for free without paying for it. But that also means that there has been some activity around getting it integrated into EHRs so that it's a little easier to use, and you're not scanning paper, screening tools. So, and anybody that would like more information on that, I'd be happy to talk about it. So this is the very overwhelming recommendation for what should happen in every well child visit. The link is here on the bottom, but this is what's called the Bright Futures periodicity table. And this is just a nice summary of all of the different things that are recommended for prevention and health promotion in the well child visit. So one thing that's important to talk about is what happens if you're doing developmental screening or autism screening and you need to make a referral. As I said, it was this came up more than once in some of the practices that we interviewed around the state, in just realizing that there's not great knowledge about the Colorado referral system. So there is help. I can help practices navigate this and understand it. Basically, it's split into 2 age groups. Children 0 to 3 qualify under early intervention. This link will take you to an online referral. It's free to families. Anybody can refer. They can do the evaluation, and then if a child qualifies, then the services are done in the home because it's recognized that that's the most natural learning environment for children 0 to 3. Children 3 to 5, then the learning environment becomes preschool. And so these kids would be getting the free preschool. Other options that are available, the state now has the universal pre-K. This is a great tool to find options for that in, whatever area you're at. And home visiting programs can be really good support for children that maybe don't have a really significant developmental delay that qualifies them for early intervention or child find, but still the family could use some support. There's some home visiting programs that can be really beneficial. So with all of this, I think, some of the challenges that still remain in pediatrics are that it's hard, especially in value-based payment. It's just there's not a lot of really good quality measures for kids that are really meaningful. So providers continue to share frustration with that, and it's something that hopefully is being addressed at a different level. But it is important. The seasonality of pediatrics makes that continuity of care really challenging. Everybody needs to be seen in July and August for their physicals so they can participate in sports, but so that makes it difficult to get in and have that continuity of care. So that's something that's really helpful for practices to kind of look at and think about. Vaccine hesitancy, we already talked about. And then really having payments in these value-based programs that focus on prevention and health promotion, because that's where the work is. And if you can't get paid for it, it's hard to focus on it. So if you are a practice facilitator and you have a practice that you think could use help with any of this, or if you're a practice and you're like, well, you know what, we're not actually doing autism screening, but we'd like to. HICPUF has contracted with the CU PIP program to continue to provide assistance to practices. And I am the pediatric person, so I would be happy to work with any practices that would like support in this area for anything related to pediatrics. So feel free to reach out and let me know if there's a way we can support you. As I said, I'll be sharing the resources for the suicide risk assessment program. I think that they're still recruiting practices, and that's been really helpful. Actually, let me put that. Thank you for doing all of those links. I'm going to put another link in here for you. Yeah, that's it. So that's for the suicide risk assessment program. And they've just, the practices that I've talked to have just really loved that program. So if that's an area that you'd like to focus on, I encourage you to reach out to them.
Folks, feel free to reach out to Mindy. Also, your practice transformation coaches, Nancy and Kayla. They're wonderful resources for you all too, and they can always connect you with Mindy as well. So just remember, we're all here for you. If folks have questions, feel free to interrupt me or type in the chat. But just for time, we're going to keep going. We just wanted to share a few things with you all about professional development and learning opportunities coming up. So we are revamping all of our trainings in professional development at NHP. And so these are trainings designed specifically for you all, providers, your staff, to follow best practice and get the support that you all need. And so in the beginning, I did share the link. I'm going to share it again. Right now, we have all of our provider training links living on our website on the page that I just dropped. I am continually updating this and adding things to this page. But on the back end, we also have a brand new training site that will be launched in the new year. So by the next time we see you at the February 1st Fridays, we'll be able to show that to you all. It's going to be really user-friendly, have a range of topics, recordings, readings, different learning styles around different topics. of anything that we've covered before or things you all have been requesting. And so I just referenced that page. It can be really helpful to go there. I also have it updated with our upcoming First Fridays topics. And so our next First Friday session will be February 6th. We will not have a First Fridays in January. This February 6th is going to be our first Fridays of the new year, and it's going to follow our new revamped First Fridays layout, which I'll tell you a little bit more about. But the topic is care coordination coaching. And so this session will really dive into what folks need around care coordination to make sure that we are providing the best care to our members. It's also going to help practices feel more supported with audits and things that come along with audits and following any standards. And so we're really excited to have this session. We're going to have our Chief of Clinical Operations, Jen Hale-Colson, present at this. And Jen is such a wonderful speaker and expert on care coordination. So we're really excited for this session. A few other ways that you all can stay engaged with us. So we have PIAC, our Program Improvement Advisory Committees. We have an urban and rural, which some of you are in. These are quarterly forums that are open to members, providers, community orgs, and partners. It's a great place for us to share resources, learn about what's going on, and go over any updates. We also have our member councils. And so if you ever have a member or hear of somebody in your community that wants to get more involved in sharing their experience of Health First Colorado or Medicaid, or maybe they're a caregiver or a parent that wants to share their experience, they're always welcome to join one of our member councils. And then with First Fridays, on that link that I shared with you all, we have the schedule for 2026 up and live, so you can see what topics are coming next year. We do have a few additional topics that we're adding. These will be pop-up First Fridays, and these are basically coming from additional feedback that we've received from providers on topics that we need to also include. So we'll share those out in the next 2 weeks as well, but we're going to have one on quality of care grievances, which will be really great. And we'll just continue to update you on those. But with this new First Fridays layout, it will have a topic that we'll focus on. There will be about 30 minutes of a clinical focus on the topic, and then 30 minutes of an administrative focus, and then time for questions. First Fridays will go to every other month. That's some feedback that we've received from you all too, that it's a lot to ask you all to come every single month. So we just really want to be intentional with the time that we have with you all and providing sessions that are really beneficial. So as you're closing out today, we'll give you a few minutes back in your Friday, but we do have a survey. It takes about 1 to 3 minutes max to fill out. It's about 4 or 5 questions, I believe. This just helps us know how you're feeling after today's session, and then what other things we can do to keep innovating and making First Fridays and provider trainings better. We really value the work that you all do, and we want to be there to support you in anything you need around professional learning. So this survey just helps us continue to grow what we're offering. And then as you're filling that out, just some contact information. We have our events page that you all received this Zoom invite from. You'll continue to receive any new First Fridays invites from that link. And then if you have questions or ideas, you want to talk further about anything, feel free to reach out to Sarah or myself. Our emails are also on the screen. And then for any information or for the resources we share today, they'll be posted on the website, but we'll also send an email out with the slides and resources that Mindy shared. I know I just said a lot to you really quickly. So does anyone have any questions or need anything as we wrap up?
So I am, let me just, pull up my slides real quick. All right. Can you guys see those?
Yep, they look great.
Okay.